Hello, I'm Lacey Grego, physician assistant with the Department of Critical Care at the Cleveland Clinic, and we'll be discussing lung ultrasound over the next several minutes. Lung ultrasound can be very useful, especially in the acute indication of a decompensated patient. This applies to differentiating causes of shortness of breath or respiratory distress. Other indications that may not be quite as pressing include shortness of breath, if you're suspicious of a pneumonia or other recurring infections, a pleural effusion, cardiogenic pulmonary edema, acute respiratory distress syndrome or ARDS, COPD and asthma, pneumothorax, or it can be used for procedural guidance such as a thoracentesis or chest tube placement as well. The probe selection for lung ultrasound can be used with the low frequency or high frequency probes. For low frequency, we typically think of using the phased array just because the smaller footprint allows us to see in between the rib spaces. A curved linear probe can also be utilized, however, will not be quite as specific to see the detail of the pleural line. Different pathologies that we think about when using a low frequency probe include looking for consolidation, atelectasis, or a pleural effusion. When we use a linear probe or a more high frequency probe, we're looking more for things like anterior lung sliding, pleural irregularities such as hydrostatic or inflammatory causes, or chest wall pathologies such as plaques, abscess, tumor, hematoma, or rib fractures, which aren't necessarily included in the lung ultrasound exam. The required views have to do with 6 major points on the chest. They are the anterior superior, the anterior inferior, the lateral axillary, as well as the posterior superior and the posterior inferior. Although a comment I'll make is that the more points that you look at, the more information you're able to pull together to determine the cause of the patient's acute changes. Each space, meaning the anterior, the axillary, or the posterior portions, also correlate with different lung fields and can be helpful if looking for a lobar pneumonia, for instance. Understanding the air-fluid ratio is very important for lung ultrasound. Unlike other solid organs or tissues or structures within the body, lung ultrasound is learning how to interpret different artifacts of how the ultrasound interacts with different percentages of air or fluid. The air-fluid ratio is represented by this diagram. At the very top, if you'll notice, we have a pneumothorax, which essentially is 100% air. In this particular view, you're seeing the ultrasound beams and waves interacting with air, for which they are not absorbed, and you get an immense amount of scatter. As pathology changes and more fluid becomes present, such as a pleural effusion down here at the bottom, where we have 0% air and 100% fluid, you will notice that your image will look different. All the other pathologies are somewhere on the spectrum in between. Here's a schematic that helps us understand and also shows some diagrams of how the alveoli and the interstitium also interact. If you'll notice on the far left, and pneumothorax is where the ultrasound is interacting with nothing but air, and therefore can get an M-mode image, such as this in the middle, which we consider to be a barcode or static image. At the bottom, you'll also notice that this is what the image would look like. The ultrasound is interacting with the pleural line and just artifact underneath. Normal aerated lung is typically considered to be 98% air, as well as 2% fluid, which is in the interstitium. With that, you'll notice that those images to the pneumothorax looks very similar, which is why we use the M mode to differentiate between the two if you cannot visualize lung sliding. As interstitial syndrome or consolidation continues to increase, where we have more fluid and less air ratios, you'll notice that the images start to change, and we'll talk about how we use the artifacts to determine what that means. This is an example of normal image, a normal aerated lung. I'd like to point out that finding the pleural line is crucial So in this particular image, you'll notice the subcutaneous tissue, the chest wall musculature. With this particular probe, which is a linear probe, you'll see a rib, another rib on the side, and in between we're going to find the pleural line. You should not be able to see anything under the rib because of the rib shadow, meaning that the rib is so hyperechoic that you're not able to see below it. And then the lung parenchyma is just represented because the ultrasound image is unable to transduce or go through the middle of the pleural line or the air. In this image, it's captured by a phased array or a more low frequency probe, and this is just an example of what that same image looks like. As previously mentioned, finding the pleural line is crucial. Without finding the pleural line, we're unsure if the artifact that we're seeing is originating from the pleural line and is indicative of lung pathology, or if it is just something else that we're seeing in the chest wall or the subcutaneous image. In this example on the left, you'll notice the pleural line is hyperechoic underneath a rib, as well as the hyperechoic shadow of the rib here with a shadow. Here's another rib with a hyperechoic line and rib shadow beneath it. A-lines and lung sighting are indicative of normal aerated lung. The image on the left is showing with a phased array probe what a normal aerated lung appears to be. Notice that you'll see A-lines, which are essentially transverse lines that are repeated throughout the entirety of your entire image. Here we find the pleural line, which we know because there's a rib shadow here, a rib shadow here. Notice each A-line is equidistant from one another. So essentially what happens is the ultrasound interacts with the pleural line, hits that interface of the air, and is reflected back to the probe. The ultrasound image is no longer able to see structure or tissue, but only interprets that scatter and then continues to repeat that image throughout the entirety of the image. On the right side, you'll notice that we use M-mode or motion mode to help determine that as well. This is what we call the seashore sign or sandy beach. The way that this image is interpreted is that this supposedly looks like sand on a beach. This is the horizon, and you can see the water below or behind it. This is capturing that there is motion on this pleural line, which is why it gets a more grainy image below, indicating normal lung sliding. Pathologic images are included with absent lung sliding and a lung point. This image on the left is indicative of an M-mode or motion mode through a pleural line that has no lung sliding. Please notice how there is just static barcode sign throughout this image. This is because we're not seeing the motion of the lung and therefore just a static. On the right here is indicative of what we consider a lung point. This is where you have normal lung sliding, as seen here on the left, is interacting with pleura without lung sliding, which is on the right. The finding of a lung point is indicative of a pneumothorax. Something to keep in mind are other causes of absent lung sliding. This can be in the case of a pneumothorax, which is only diagnosed with a lung point, pleurodesis, severe asthma or COPD, a main stem intubation, a large bleb, apnea, or a pneumonectomy. So to recap that point, absence of lung sliding can be suspicious for a pneumothorax, however, not diagnostic. A lung point confirms the diagnosis of pneumothorax. Other pathologic images we consider are B-lines, and this is when there is a thickening of the lung interstitium, such as in pulmonary edema, interstitial inflammation and/or infection, and pulmonary fibrosis. Features of B-lines include a comet tail artifact arising from the pleural line, well-defined laser ray-like lines. They're hyperechoic. They're long, meaning that they transverse the entirety of your image all the way to the bottom. They will obliterate an A-line if it exists, and it moves along with lung sliding. Other pathologic images include alveolar consolidation, which include a tissue-like sign, which can be seen here in the image on the right. This is where the lung mirrors or looks like a solid organ, such as the liver. This is indicative of alveolar consolidation, such as pneumonia or atelectasis. Other signs include the shred sign or air bronchograms, which are pictured on this slide. A shred sign essentially looks like you've taken a piece of paper and you've shred it apart. This is indicative of having consolidated lung, which is similar to that tissue-like sign, but the shred or the paper tear is indicative of where consolidated lung interacts with aerated lung, creating this bright white line, and that's the shred sign. The image on the right is indicative of air bronchograms, which are these bright white spots noted in this consolidative lung. This is indicative of the ultrasound beads interacting with air within the bronchograms, surrounded by consolidative alveolar processes. Other pathologic images to consider are the pleural effusions. These are 3 examples of pleural effusions that can be described with a little bit more detail. On the farthest left, we have the complex pleural effusion. If you'll notice, it's a lot of hypoechoic fluid above the diaphragm, but you can see some graininess or haziness within there. This is indicative of some type of thicker material within a simple effusion. In the middle, you'll see a complex septated pleural effusion where you can see the proteinaceous capsules of the fluid within inside the pleural effusion. And on the far right, you'll see the loculated pleural effusion, which is well defined by the proteinaceous outer wall of this loculation here. Closing comments I'd like to make. You must find the pleural line to interpret lung ultrasound. Otherwise, you may just be seeing artifact that is interacting with air or water with the ultrasound and can be unsure if that is truly what's happening with inside the lung. Understanding the air-fluid ratio is key to lung ultrasound interpretation. Lung ultrasound, unlike solid organs or other tissues, is just understanding how the ultrasound beams are interacting with air and fluid, which with that information we can derive what pathology is actually going on. A sliding pleural line with A lines is indicative of a normal aerated lung. The lack of lung sliding is only suggestive of a pneumothorax, but not diagnostic. There are several other causes that can cause lack of lung sliding. A lung point is, however, diagnostic of a pneumothorax. B lines are suggestive of interstitial edema. A consolidative pattern suggests pneumonia or atelectasis and can be seen by things like the shred sign or the tissue-like sign. Lastly, pleural effusions are most common in the posterior lateral chest and should be a place to look at whenever you're doing your lung ultrasound protocol. Thank you for your time.